Hello, everyone. Let's get started. My name is Alan Hudson from the Immuno-Oncology Translational Network Data Management Resource Center. I'm also chair of Biostatistics and Bioinformatics at Roswell Park Comprehensive Cancer Center. I'd like to make a few points about today's seminar. In supporting the next generation of cancer researchers, today's Cancer Moonshot Seminar will feature research from talented junior investigators. These are abstract-driven talks nominated by Cancer Moonshot investigators and selected by NCI staff. A few bookkeeping items to review. Questions will be responded to at the end of the second presentation. Please enter your questions in the Zoom Q&A box. The audience can actually prioritize the questions by clicking the thumbs up button. Closed captioning is available. The closed captioning for today's webinar can be accessed by clicking on the live transcript option in the Zoom menu at the bottom of your screen. Instructions are also provided in the chat box. The recording of today's webinar will be available a few weeks after today's presentation. With that, I'd like to introduce our moderator, Dr. Roxanne Jensen. Dr. Jensen currently co-leads the Centers on Telehealth Research for Cancer-Related Care Initiatives, focused on generating robust evidence base for patient-centered, sustainable telehealth models for cancer care delivery. Dr. Jensen also serves as a scientific lead for the SEER Medicare Health Outcome Survey data resource, which provides information on cancer health outcomes. She is a science officer for the Improving Management of Symptoms Across Cancer Treatments Impact Consortium, a Cancer Moonshot initiative designed to evaluate the implementation of systematic symptom management and cancer care delivery. Dr. Jensen.
Thank you so much. I know it's a mouthful full of acronyms, right? It's my pleasure to be here today to introduce and moderate two wonderful presentations highlighting some great work done through the Cancer Moonshot. Up first, I'd like to introduce Dr. Erin Bange. She is a medical, She's a medical oncologist who treats gerontology oncology patients at Memorial Sloan Kettering. She's completed her medical training that includes a master's in clinical epidemiology at the University of Pennsylvania. And her research focus is in implementation science and pragmatic trials with the goal of designing and testing novel care delivery paradigms that better connect the home and clinic to provide more patient-centered care. Erin, thank you so much. It's a pleasure having you here today with us.
Thank you. So give me 1 second just to get my screens all set up. All right, so good afternoon. Like Dr. Jensen said, my name is Erin Bange, and thank you for giving me this opportunity to share my research as part of MATCHES, which stands for Making Telehealth Delivery of Cancer Care at Home Effective and Safe. So the key question of our research group is really, in what circumstances is telehealth effective for delivering cancer care? So over the last 2 years, MSK received a grant from the NCI as part of the TRACE initiative and under the umbrella of the Cancer Moonshot to create the MATCHES Telehealth Research Center. The TRACE initiative has funded 4 total institutions to establish multidisciplinary centers to build the evidence base necessary to establish best practices for telehealth-enabled care. Our center has 3 primary objectives. The first is to develop the concept of precision care delivery, with the goal of matching individual patients with the most beneficial combination of clinic-based and telehealth-supported home setting care at the appropriate time. The second objective is to implement pragmatic trials to test novel care delivery strategies that leverage telehealth. And the third is to train the next generation of researchers to continue moving this line of research forward. Today, I'm going to take you through each of our research questions and review with you our approach to tackling our critical objectives. Oops, sorry. So the next key question is, can we identify biomarkers for cancer care delivery and determine when remote telehealth or in-person care is safer and preferable? So to do this, we are establishing the MATCHES retrospective database, which is really trying to create a research commons for use by multiple different researchers to really try to understand how and when to deliver telehealth for patients with cancer. And so to establish this, we are pulling data from multiple different data streams, including clinical data, research data, and operations data. And as I highlighted earlier, our primary objective is to really create this concept of precision care delivery. So one, to develop risk prediction models to identify which patients can safely receive telehealth and when. And two, to identify and define data-driven clinical pathways to really help guide clinicians in real practice in terms of when and how to use telehealth to take care of cancer patients. And two is trying to see if we can develop the concept of digital biomarkers. So different patient and clinical phenotypes that may indicate to us when telemedicine is best serves the patients and when actually we should be delivering our care through in-person clinic visits. Our second question is, can we expand the current model of telehealth to include home clinical care? So as most people on this call probably know at this point, telehealth has really transformed how we deliver care, how we can deliver care to patients, but it really only tackles one component of the cancer care spectrum. So things like laboratory testing, imaging, treatment still has to be delivered in brick and mortar facilities. And so our vision is to create what we call an expanded telehealth model, where we take some of these components and actually move them to be able to be delivered in the home setting. Things like getting home phlebotomy visits, being able to monitor patients' vital signs using remote monitoring devices, and being able to give patients treatment in their home setting. And so to be able to determine if this is actually feasible, we are doing a series of different pragmatic trials. So the first is we call Match Up. And so this focuses on patients with breast and prostate cancer. And the current model of care for these patients really demands the patients to frequent brick and mortar facilities for monitoring and treatment, which can cause significant time and financial burdens on patients. As I've highlighted earlier, we have had advances in technology, mobile phlebotomy, and oral injection-based treatments that now allow us to think about this concept of enhanced telemedicine and actually delivering these services in the patient's home. And we do know that prior cancer at home initiatives have been quite successful with low rates of complications and high patient satisfaction in multiple different types of cancer malignancies in both the solid tumor and hematologic spectrum. And so the big picture is for us to do an institution-wide pragmatic trial where we are enrolling patients with breast and prostate cancer who are receiving treatment with oral or subcutaneous-based therapies. And what we're envisioning doing is randomizing our 8 different oncology practice sites to either the usual care model or our vision of a enhanced telemedicine program, and ultimately trying to see, can we reduce the amount of times patients have to physically be coming into the brick and mortar facilities, but at the same time looking at other dimensions of care quality, so things like efficiency, trying to understand the patient and the clinician experience, as well as their satisfaction with this type of care delivery strategy, as well as to define the barriers and facilitators to standing up a program like this so that it could be done in multiple different types of clinical settings outside Memorial Sloan Kettering. So before we did this, we actually completed multiple semi-structured interviews with different stakeholders, including patients, physicians, administrators, nurses, and pharmacists, to try to understand what will really be necessary to stand up this program. And while the majority of stakeholders did report feeling very or somewhat likely to participate in a program like this, we did identify multiple key things that we would need to address before launching an institution-wide program. It was emphasized the need for quality assurance for each of the components of the home program to make sure that we're continuing to deliver the best care for our patients. The stakeholders emphasized the need for deliberate protocols, not only for onboarding patients and staff, but for troubleshooting any issues that may happen in the home, as well as trying to figure out who are the right patients and when to implement this program. It was critical that we had key workflows for establishing safeguards, particularly for giving medications in the home setting, as well as defining alerting parameters for any of the vital signs or blood work that was collected in the home setting, and make sure they were getting delivered to the right clinical team at the right time. There was also attention needed in terms of picking the right drugs for doing in the home setting, as well as to make sure that all of this data that we're collecting at home was protected in terms of patient privacy, And then that all of these procedures that we were setting up were attentive to the staff's need in terms of not creating any excessive work and their already quite burdensome schedules. So this led us to ask, is an enhanced telemedicine model acceptable, appropriate, and feasible? So to answer this, we are currently running a pilot study where we're looking at a smaller cohort of patients, approximately 30, trying to get at least 10 participating in each of the home services to really try to understand what we need and how we can stand up a larger institution program. And so for this pilot, we're really focusing on patients with prostate cancer on androgen deprivation therapy. So to dive a little bit deeper into each of these components that we're looking at, the first is home phlebotomy. And so MSK has already been piloting this program, and they've been partnering with a vendor called My On-Site Mobile Phlebotomy. And essentially how we've been working this is that the clinicians put an order into our electronic health record, which then prompts a phlebotomist to come to the patient's home, collect the sample, then bring it back to our brick and mortar facilities to be processed, and then ultimately reported in our EMR like any other lab done throughout the MSK system. We've actually been able to do over 1,000 visits so far across multiple states, including Pennsylvania, New Jersey, New York, and Connecticut. The second service is at-home vital sign monitoring. And so to do this, we are really looking at 2 different devices that we have been giving to patients. One is a pulse oximeter through iHealth, and the second is a blood pressure cuff through Omron. And what we've been doing is essentially enrolling patients, so it's giving them an educational session and helping them set up the device, download the necessary apps, and link the devices through Bluetooth to their cell phones. And then once everything is set up, the data, once they collect their vital signs, the data is transmitted through encrypted HIPAA compliant servers and then saved on a remote monitoring database for then to be used to create dashboards for clinical use, to then deploy those alerts that we identified were so important to get to the clinical teams, as well as to ultimately being reported in the electronic medical record for clinical use. And then finally, we have the at-home injection component. And so what we've been doing is really supporting patients and their family members into self-administer medications. And so what we've been doing is having patients or their caregivers have a training session with a nurse practitioner on the preparation, administration, and disposal of the medication. We've been providing them with all necessary training materials on how to do this. And then we provide the option at any of their injection, at the point in time for any of their injections, to have a nurse or a nurse practitioner available over telehealth to help guide them in the injection if the patient would like that. We have been preferably filling these medications through our MSK pharmacy, but if the insurance company for any way refutes that, we will go through the path of least resistance and have it dispensed at their preferred insurance and their preferred pharmacy. So far we have enrolled 23 patients, and we've had a range of different patient demographics represented in our cohort, including patients with different races, with different treatment intents, so both patients getting curative and palliative regimens, patients in different living situations. So we have patients who are living by themselves, as well as patients who have support from friends or family who maybe they be living with. And we also have patients from a different range of educational attainment, as well as yearly income. And we've been really trying to be quite diligent about enrolling a diverse cohort to ensure that what our ultimate design for our final institution-wide pragmatic trial is attentive to the wide needs of a very diverse population, so that we don't have any patient group that wouldn't be accessible to this program. So far we have preliminary data from about half of the participants. And so far, 10 out of 10 have really reported that they would be likely to participate in that program again, that they felt that this was less stressful or equally stressful as the care they've received in an in-person clinic, and that they actually would prefer to continue to get their care done in the home setting. And when we asked them to kind of tell us what are the specific benefits that they've received, all of the patients felt that it was more convenient, and the majority felt that it saved them time, and gave them more control over their schedule. And other patients highlighted that it allowed them to save money, that they felt like they were getting better monitoring, and that it was more convenient for their family. But with that said, we have learned quite a bit about how to actually do these types of programs and what is necessary. So the first thing is that we've really learned that it's quite important to have a robust and validated infrastructure. So one thing is that it's really necessary that the devices that you are using are validated for in the patient cohorts that you're using. And so cancer patients come in all shapes and sizes. And what we've learned is that for the prostate cancer patients, the original device that we were using actually didn't have a cuff size that was large enough to accommodate some of our cancer patients. And so we actually had to switch vendors halfway through to make sure that we were getting reliable measurements. And so it was a really good lesson for us to learn to make sure that the devices fits the patient population that you're using and that it's well integrated into your clinical system. We've also learned that it's really important to have a robust workforce to support any troubleshooting issues that may come up along the way for the patients, and that the skill set that the standard clinical team who supports patients may not be the same as what is needed to help them navigate issues that come up, particularly with things like remote monitoring. And also that it's really critical to have the infrastructure and the supports to navigate all of the logistics of onboarding the patients, getting the devices sent to them, and coordinating appointments. The second thing that we've learned is that communication is critical. And this is really a three-way communication between the patient, the clinical staff, as well as the pilot and the pilot team. And this is critical to, one, make sure that everybody is appropriately educated and supported in terms of what they're doing and how to navigate an enhanced telemedicine program, but also that there is seamless documentation in terms of what is going on for the patient. So for example, if the clinical team wants to have labs done every week or every other week, it's really important that all of those members of that trifecta knows what's going on, what the patient needs, when it needs to happen, so that the patient is ensured to get the highest quality of care possible. The third thing is that we've learned a bit about fitting the right ideal clinical scenario with the enhanced telemedicine model and some of the different needs for different patient groups. So one thing that we've learned is that for some patients, that initial onboarding visit and training session really needs to be done in person, and that trying to do it remotely really is a disservice to the patient, and that kind of investing in that in-person visit really kind of allows for a long-term benefit in their ability to kind of stay in the program. We've also learned that some drugs are easier to do in the home setting than others. So for example, subcutaneous injections are much easier for patients and their families to navigate at home than things like intramuscular injections. And finally, we've learned that there's a lot of important considerations for costs, and to make sure that we are not, especially when we're dispensing medications through an outpatient pharmacy, that we're not adding on any additional financial burden to patients. And finally, there's really important institutional considerations to consider when standing up programs like this. So one thing that we've learned is the more we're able to integrate our workflows with the clinical workflows that are already established, the more success that we're going to have. The second thing we've learned is that these types of pragmatic trials and research that span the clinical domain and the research domain can be quite tricky, in that it's really important to identify what are the types of things that are going to be done by the clinical team and what are the things that are going to be done by the research team, and have it be very clear cut, and that there are certain skill sets that better align with different staff. We've also learned that there's a lot of legal and policy challenges when moving care from a brick and mortar facility to the clinic. So one is not only on the institutional landscape, but also in terms of state and federal policy. So for example, if a clinician has a patient in Connecticut, but they're not licensed to practice there, then they may not actually be legally able to deliver care. And we've been using this as quite motivation to continue this type of research, to really try to advocate so that patients have access to this type of care model. And finally, when we're trying to implement something like this across a large institution like MSK, we've learned that there are multiple different microcosms and microcultures even within the institution, and that it's really important that when we develop these protocols, that they're nimble enough to be able to be adapted to different environments, even within one system. And so finally, our last question is, can we think about implementing this type of approach in another clinical setting, such as pembrolizumab? So pembrolizumab is an immunotherapy approved for use in many solid tumor malignancies. The original approval was for an every 3-week dosing paradigm, but during the pandemic, the FDA approved an alternative 6-week approach. We believe that the less frequent dosing algorithm to be more patient-centered, improving patient access, minimizing unnecessary financial toxicity, and improving quality of life. Despite this approval, though, every 3-week dosing remains the standard, as clinicians perceive this schedule enables them to identify and manage toxicity earlier. So our question is, can maybe telemedicine could be the impetus to change the standard to the more convenient 6-week in-person treatment schedule, but more evidence is needed. And so what we are doing is another pilot study where we're enrolling patients, approximately 50, who have solid tumors who are receiving pembrolizumab monotherapy, and monitoring them prospectively to see how this can be achieved and whether we can lower the proportion of routine in-person oncology visits. So patients essentially come into the brick and mortar facilities every 6 weeks for an in-person visit, and then they have interim 3-week telehealth check-ins for toxicity. And these can be augmented per the clinician preference with remote vital sign monitoring or home phlebotomy visits if the clinician feels it's necessary. And we are also exploring, similar to the match-up study, other dimensions of care quality to really try to understand how this works for both patients and clinicians. So in conclusion, telemedicine has really created an opportunity to expand patient-centered cancer care. Further research is needed to understand the best clinical environment for its use. And we believe an enhanced telemedicine model of care creates the opportunity to deliver more care in the home setting and minimize the burdens associated with routine cancer treatment. But further research is needed to identify and address the barriers implementing such a program, especially when we think about trying to expand it to multiple different care models. And so I wanted to thank our whole team at the Matches Center who's doing this robust work, and really for all of your attention and this opportunity to share our program. Thank you.
Wonderful. Thank you so much, Erin, for your presentation on telehealth. I've seen some questions in the chat. We're going to hold all questions to the end, but I encourage you to submit them as we move through the presentations. All right. Up next, we have Dr. Callie Walsh-Bailey. She's an assistant professor in the Department of Medical Social Sciences at the Northwestern University Feinberg School of Medicine. Her research is focused on the intersection of implementation science, health equity, and prevention and control of cancer and other chronic diseases. Go ahead and take it away.
Thanks so much, Dr. Jensen. And good morning or good afternoon, depending on where you're joining from. It's such a pleasure to have the opportunity to share a bit about this work, which I completed as part of my dissertation at the Brown School at Washington University in St. Louis in December. So I'm a freshly minted faculty member at Northwestern. So I'll be sharing a bit about my dissertation work, which focused on developing a resource to guide the design, tailoring, and specification of equity-focused implementation strategies. And I'll talk a bit about where I think I'm going to take this work in my new faculty role. And for folks who are new to implementation science, don't worry, I will unpack what all those terms on the first slide mean, and then I'll actually get into what that resource is. I'll share some brief results from my preliminary user testing and discuss some future directions. I'm going to start first, though, with a definition of health equity, since this is really the foundation that guides my work. Health is a fundamental human right. And so health equity means ensuring that everyone has the opportunity to achieve their optimal health. Equity recognizes that we all start in different places and that our needs change over time, and that there are systemic unfair differences in society between those who are best and least well off. Health equity work requires recognizing and correcting historic and current unjust social structures and policies that lead to unfair preventable differences in health. And rather than assuming that everyone needs the same thing, the goal of health equity work is to provide resources according to need. As we see in this framework and many others, health equity is often framed as this ideal outcome that we're pursuing. But Kamara Phyllis-Jones really poses health equity as a process. So it's not just a box we can check, but it's work that requires continuous inputs and actions. And so this conceptualization is really what drives my work. So we have done a lot of work in research to understand the causes of diseases such as cancer and what works to prevent, treat, and eliminate those diseases in order to improve health. We invest a lot of resources in research, but unfortunately, most of this research doesn't make it into routine clinical and public health practice. And what does make it takes a long time to do so. And so this often cited leaky pipeline is what we're trying to address in implementation science. And just to make that really concrete in cancer, we know that there are vast inequities in cancer control outcomes among marginalized populations. For many types of cancers, screening is lower among Black, Asian, and Latino populations compared to white populations. People of color are more likely to receive later stage cancer diagnoses, are less likely to get guideline concordant care, and have worse survival outcomes. Minoritized sexual and gender identities are more likely to experience delays in diagnosis and treatment and have higher likelihoods of cancer recurrence. So we have this huge gap between what we know works and what people actually receive in routine practice and who actually receives what works. So I've copied the NCI definition of dissemination and implementation science here, or I'll say IS for short, or implementation science. But in a nutshell, the goal of this field is to close the gap between what we know and what we routinely do in clinical and public health practice. We can't stop after effectiveness research because interventions can't help anyone, even if they work, if people don't receive them. So implementation science complements and is really an integral part of this translation pipeline in getting us to improved population health. And I really view implementation science as a vehicle for advancing health equity. So in effectiveness research, we're focused on the what, so the treatments, the programs, the pills, the policies that work to improve health. Implementation research really unpacks all of the steps in between getting us from an evidence-based intervention to improved health outcomes. So much of our work is focused on identifying effective implementation strategies. So these are the tools, methods, or actions that we use to enhance the adoption and routine sustained use of evidence-based practices. So these strategies are meant to overcome barriers or challenges that make implementation harder, or leverage facilitators that make implementation easier. And so we think about the outcomes of those strategies, which are a little bit different than our typical health service and patient outcomes, but they're really an important piece of the pathway in getting us to improved population health. So there are many strategies, there are dozens of these. This is just a very small selection. So you can think about approaches to train or educate folks who are supposed to be delivering that intervention, using mass media or other techniques to engage consumers or recipients of that intervention, making changes to infrastructure, whether that's record keeping systems or actual physical or electronic infrastructure. So again, dozens of these, but this is going to come back in a couple of slides because this is really the focus of my work. So in my dissertation work, I built upon and expanded existing definitions of value-based and equitable implementation to pose this guiding definition that I really try to center in my work. Really, I'm thinking about turning our researcher as the expert, our top-down scientific paradigm on its head, to center and amplify the needs and the lived expertise of individuals and communities whose health we are trying to support. So making sure that they have a real say in what gets implemented and how. If we want to achieve more equitable health outcomes, we need to think about equity, not just in our interventions, but in our implementation efforts as well. Until recently, health equity has been an implied goal in implementation science, but was really absent from early foundations in the field. Thankfully, health equity is receiving increased attention in implementation science in the past few years. This is just a small sampling of much of the really exciting, wonderful work so many folks in the field are doing. A lot of this has been around recognizing the challenges to advancing health equity in the field and recommendations for what we need to do to better integrate equity in our work. So lots of energy around this, but we still have a long way to go. And I became really interested in this topic of equity-focused implementation strategies because as calls to the field increase for us to focus on equity, one of the recommendations is to include an explicit focus on equity in our implementation strategies. So again, that scaffolding that we put around our evidence-based interventions to put them in place. However, there's not a ton of concrete actionable guidance on how to actually do this. Again, health equity has largely been absent from our guiding methods, our theories, models, and frameworks in implementation science, and particularly around how we select, tailor, and design our strategies. Other resources have been developed recently, such as the Implementation Science Centers in Cancer Control Health Equity Toolkit, and the Health Equity extension of an existing implementation science models web tool, but those don't focus explicitly on implementation strategies. One of the few pieces of available guidance around designing equity into our implementation strategies is Aspire, which offers a really valuable starting place. So this framework calls for making our assumptions about implementation explicit, which is super helpful in getting us from equity as an implied goal of our work to a central, clear focus. But one of the limitations is the steps don't quite align with our prevailing guidance for specifying implementation strategies, and researchers who are newer to implementation science or to health equity work really need detailed, concrete guidance to be able to operationalize equity in their strategies. And so when I'm talking about specifying strategies, this is guidance that Anola Proctor and colleagues put out about 10 years ago. So if you think about when you go online to find a recipe, it's really nice when all the ingredients, the amounts of those ingredients, and the steps that you need to do to prepare a dish are laid out. The more specific and concrete that recipe is, the more likely you're going to be able to recreate that recipe and get similar results. So that's what we want to do with our implementation strategies. So if we think about getting to equitable implementation, we want to know what those key ingredients are that have worked so that we can report those and that other people can replicate our efforts. And so our prevailing guidance tells us to name our implementation strategies, ideally with an existing label from one of our strategy taxonomies. And when we define our strategies, when we lay out those key ingredients, we think about all of these components shown here. So who is actually delivering that strategy, or in other words, who's the actor? What actions or steps or processes do we need to take to carry out that strategy? What are we targeting with that strategy? So what are we trying to change? Are we overcoming a barrier? Are we trying to change a certain behavior? And when and how much of that strategy is delivered? So what is the temporality and dose? What implementation outcomes are we trying to affect? So are we trying to make that evidence-based intervention more feasible to deliver by using that strategy? Are we trying to make it better sustained over time? So thinking about what implementation outcomes we're changing. And then finally, what is our rationale or justification? So what empirical evidence, theoretical guidance, or pragmatic evidence do we have to support our choice for those strategies? So the goal of my dissertation work was to develop concrete, actionable guidance that implementation researchers can use to create that recipe for their implementation strategies with equity as a key focus. So trying to address one of those recommendations to the field of implementation science. And I want to acknowledge NCI for supporting this work through an administrative supplement award. So this is the general process that I undertook. It was really an iterative development, user feedback, and refinement approach. So I collated implementation science and health equity literature from various sources, including a scoping review of health equity frameworks as part of my dissertation, as well as existing repositories and bibliographies of equity-focused implementation science and public health literature. I gathered feedback from 3 mentors who have expertise in equity-focused implementation science on my early kind of synthesis of this information and presentation of it in a resource to guide our strategy design and specification, and then carried that forward into user testing. So my methods for testing and refinement were informed by user-centered design and rapid prototyping approaches. In user-centered design, we're told that we can't design for everybody, that we need to have a sufficiently narrow, defined user to develop for, and then we can build out from there. And so based on feedback I received in an implementation proposal bootcamp, I narrowed my target users specifically to implementation researchers who are early to mid-career, who might be newer to that field or to the field of health equity research, with the idea that if I'm narrowing to an audience that has some foundational knowledge, but is not necessarily an expert, I'm not precluding more advanced folks from using this resource, but really thinking about making this inclusive for users at different levels. The current resource is a Word doc. It's about 16 pages long, so it's too much to show in its entirety. So I've added some screenshots just to give folks an at-a-glance sense of what this looks like. So the first page of the resource is just a brief introduction summarizing the purpose and the scope of this resource. So who is it intended for and what content it contains. The first section has a table of guiding terms and definitions related to health equity and equitable implementation. I collated a brief annotated bibliography of health equity literature, and I include links to existing equity-focused implementation science resources. So my goal really is not to reinvent the wheel. Folks are already doing a lot of wonderful work in this space, and so I'm trying to complement and extend existing resources. The second section has a brief summary on implementation strategies, including that figure from Proctor and colleagues I showed a few slides ago that illustrates our recommendations for specifying implementation strategy components. The meat of this guide is a brainstorming activity that's broken out in two parts that helps users consider and articulate equity in the components of their implementation strategies. So the first part of that brainstorming activity has a set of overarching questions that really cross-cuts implementation, isn't falling just within one specific piece of an implementation strategy. So this includes guidance around having researchers articulate their positionality and their existing assumptions and knowledge that they have about their implementation work. And this also includes a set of user tips, which I gathered through my user testing sessions. And so really building in user feedback as I received it. The second set of prompts are provided in a table which is organized by those implementation strategy components I showed. So again, the actor, the action, the target, the dose, the temporality, et cetera. So users are instructed to describe a strategy that they're starting with and specify those components with as much detail as possible, and then think through prompts that interrogate how equity might show up in each of those pieces of their strategy. And based on their responses to the prompt, think about how they can redesign that component of the strategy with a greater focus on equity. The final section of the resource includes example responses to those brainstorming prompts by each strategy component and the resulting implementation strategy components. So really providing a concrete example of what did the starting strategy look like and where did we end up based on going through that brainstorming activity. And so I'm going to walk through a brief example to make this really concrete for folks. So if we're thinking about an evidence-based intervention that we want to implement. For example, in 2021, the U.S. Preventive Services Task Force issued new recommendations for people of average risk to start being screened for colorectal cancer at 45, which was 5 years younger than the previous recommendations. So we might think about some barriers or some challenges. What are things that are getting in the way of patients receiving guideline concordant colorectal cancer screening? Well, the literature tells us some of these barriers include provider knowledge and awareness of updated guidelines. Providers are not communicating to patients about screening and the available options. And so patients don't know that they should be getting screened and how they might do that. We also know that particularly for people of color, there have been a lot of harms caused by the biomedical system, which contributes to patient hesitancy and mistrust. And there are also social risk factors such as the lack of transportation, lack of insurance, or cost of screening that also might make it hard for patients to get screened. One strategy we might use to address some of these barriers is training. Training that includes an educational component or providing information is suited for increasing knowledge and awareness. Training with hands-on practice components can help to improve skill deficits and self-efficacy in carrying out a desired behavior or practice. So, for example, improving provider efficacy in talking to patients about the importance of screening and what those screening options are. Now, training is not going to change those social and structural determinants of health, but can raise awareness of those so that they can be considered in care delivery. So to give folks an idea of what the brainstorming activity looks like, I've included just a small subset of example prompts, as well as what the starting strategy component of that implementation strategy of choice might look like. So again, thinking about training. The prompts are organized by Proctor's strategy components. I added a couple of things to really get more granular and detailed in reporting out on the strategy. And so modality is something new. So this has users think about the approach or the methods to actually deliver that implementation strategy, as well as measurement. So what indicators are we measuring that tell us that that strategy is working in the way that we want it to, and how do we actually need to measure those indicators? So this is organized just a little bit differently than it is in the resource, but wanted to give folks some ideas. So in thinking about the actor who delivers that training, we might start with a physician clinical champion who is knowledgeable about the colorectal cancer screening guidelines. One of the prompts from the resource asks users to consider the power differential between actors who deliver the implementation strategy and the recipients of those strategies, and how power might be more fairly distributed. So you might start with, again, that physician clinical champion. And in thinking through that brainstorming prompt, you might also include peer-nominated non-physician roles, as well as patient advocates as trainers to, again, more equitably redistribute power. And thinking about the action, or again, the steps or processes that we need to do to carry out that strategy, one of the prompts asks what additional actions are needed to better serve marginalized groups and settings, and offers some examples of what types of actions might be included. Your starting strategy might include didactic education and participant Q&A on the colorectal cancer screening guidelines. So it's really just information provision. And thinking about those brainstorming prompts, you might also have patient advocates who represent marginalized groups share information about historic and current reasons for patient hesitancy or mistrust, and why patients might not be getting screened. And you might also show clinical data on screening inequities. So are there racial or ethnic disparities in who is getting screened in that clinic, or perhaps rural urban disparities? So you can identify really where the breakdown is in care delivery is, and work on improving that. And thinking about the modality, one of the brainstorming prompts has users consider where and how the strategy is delivered. So thinking about physical and virtual spaces and the types of written, audio, visual, or other types of materials that are used to deliver that strategy. And thinking about how that modality takes into consideration the needs and abilities of recipients, whether that is mobility needs, language or literacy, and what potential accommodations recipients of that training strategy might need. So you might start with a training that's delivered over Zoom, live and recorded like today's session is, and you might email handouts to training recipients. Based on your brainstorming, you might decide to improve the modality in a few ways by simplifying the wording of training materials, adding captions, larger fonts and visual aids, providing hard copies of handouts if color printing is a challenge in clinics, and offering flexible delivery options, so virtual, hybrid, or in-person training in physically and geographically accessible space. So I'm not going to go through all of these, but again, just want to show folks a few ways that this resource prompts users in thinking about how they might specify equity implications of their strategies, or redesign a strategy with a greater emphasis on equity. And I know I'm running short on time, so I'm going to run through some user testing results really quick and finish up with some future directions. So in user-centered design, the goal of prototype testing is to identify major problems that impact the usability of a product or a tool, rather than fine-tuned refinement. And so this formative testing has small sample sizes. So my target sample was 8 to 10. I ended up with 8 interviews and a 9th participant who couldn't participate live due to illness, and so provided written responses. Participants were all women representing diverse racial and ethnic backgrounds, disciplinary backgrounds, but with a common thread of working in implementation research, but very broadly across populations, settings, and disease topics. So I sent the Word document of that resource in advance of the interview. And then in the user testing sessions, which were 1 hour over Zoom, I had a semi-structured interview guide with questions around health equity and implementation science, user needs and preferences for resources to guide equity-focused implementation research, and then had a think out loud review of that strategy resource. So how do users kind of stream of consciousness articulate likes, dislikes, points of confusion, and recommendations for each section of that resource. And then I finished up with a 10-item post survey from the cognitive walkthrough for implementation strategies that really focuses on usability of the resource. So the usability survey scale ranges from 0 to 100, with 100 being ideal usability. My average for this sample was 82.4, ranging from 72 to 100, indicating participants thought that the guide had acceptable to excellent usability. Participants liked the table of terms and definitions, the strategy component figure, the user tips and suggestions, and really appreciated the concrete case example of going through that brainstorming activity. Participants noted uncertainty around the target user, so who counts as an implementation researcher or part of a research team, and participants wanted further explanation of how to actually approach that brainstorming activity. Participants, one of the big pieces of feedback was that if we're really thinking about centering equity in our work, this can't just be one researcher making these decisions about these strategies, but this needs to be a collaborative approach, which is leading me to my future directions. So the initial version of this resource was responsive for a need in the field for concrete tools. It collates health equity and implementation resources. Some of the limitations were the small sample size, and that 1 hour session was really insufficient to build out concrete case examples. So I kind of piecemeal developed one. So what I'm really hoping to do at this point is take what I started with and really test this among multidisciplinary research teams with academic partners. So really community engaged and participatory research to have that collaborative approach to making decisions around implementation strategies. And my long-term goal is to make this into an open access living resource that other folks can use to integrate into their implementation research and can really build upon as the field expands and our science advances. So I want to thank so many folks who made this work possible, including my dissertation committee members, the investigative team from the R01 for which I received my supplement, as well as my study participants. And I'm currently working on a K-12 to support that team-based user testing and would love to collaborate with folks. So please feel free to reach out if you want to learn more or if you want to connect. Thank you.
Wonderful. Thank you, Dr. Walsh-Bailey and Dr. Bange. Let's get into some questions. I really enjoyed both presentations. They really show a lot of the nitty-gritty of cancer care delivery and some of the challenges we have in figuring out how to cross over a gap between kind of what we know and what the realities are in care. And so I guess a larger question for both of you, telehealth has rapidly increased over the last few years due to the pandemic, particularly this type of telehealth where we're talking and using video technology. But it's kind of akin to building a plane as you're flying. We really don't have a good sense of what the evidence base is or what we need, what is successful. So it's not. So in this area, you know, there is a gap, but we actually don't quite know how wide it is. And then there's issues of digital divide. And we're not quite sure whether telehealth can entrench health disparities and issues or ameliorate or improve things. From both of your perspectives, like what do you think about is important to be thinking about in this kind of situation where things are moving incredibly fast and we don't quite know where we're going, but these issues are really important?
So I think this is essentially like what we're trying to do in our research center. And I think it is quite challenging. I think in the pandemic, the weird cryptic blessing of it was that it actually just kind of forced us to use telehealth and really moved it from something that was really in the limited to very rural communities and very specific use cases. This is something that was being deployed and across the country for all patients. But I do think that it's really important to kind of take a step back and really look at what has been happening over time. And so a lot of the data, to the limited data that has come out, has really been specific to the pandemic time period. And so I think it's essential that we look at how have things changed over time and in different clinical scenarios. And so, you know, what was being done in April 2020 is probably different than what's being done now. And so looking at how care has changed and really looking at different populations. And then, like Callie was highlighting, I'm sure she'll speak to this more, really looking at, you know, engaging with patients to try to understand, you know, how their perspectives of this have changed over time. And so even just doing the limited research that I have done, you know, some things can be quite surprising in terms of, you know, when and how patients want to interact with these types of services. And I think what's going to be really important is to create a model of care that's very nimble, we don't go back to a one-size-fits-all model in any way. And so that we have this toolbox of different ways to enact care, and we figure out when and how to use these different tools when it's safe, but also when it aligns with the patient's goals. And so we just, as a whole cancer field, become more nimble. And I think if we can do that, we can then kind of capture a larger population and try to not leave anybody out in terms of the digital divide for whatever reason that is, whether it's their preference or certain other barriers.
Yeah, I'll probably echo a few of the comments that I heard. And I think really put a plug in for implementation research. I didn't present on this, but some work that I was involved in looking at cancer control in the context of COVID in rural Missouri and Illinois. We heard so many great examples of local successes and really creative, innovative solutions to help get patients the care that they needed and to bridge that digital divide. And I think there are also some misconceptions that have real implications that are played out in policies and funding that really need to be addressed to make sure that we are actually not perpetuating that digital divide. So to comment on, you know, some of those local solutions, it was anything from providing patients in the parking lot with iPads so that they could engage in a telehealth appointment if their provider was, you know, only doing sick visits and they needed to talk about getting a referral for cancer screening, for example, or to follow up on test results. There was partnerships with labs to do more home mailing of test kits and more educational materials for instructions for completing that, and a lot of cost sharing or redirecting. Some of the challenges that my colleagues and I have experienced is funders don't often want to fund research on telehealth and digital health in rural settings because there's this perception of people in rural communities don't have broadband access, don't have you know, the technology to be able to engage, and that's not necessarily the case. We do know in Missouri, for example, some counties, a third of households don't have digital access, and that is definitely a challenge, but 2/3 do. And so by not wanting to fund research and practice in rural settings, we're really doing a huge disservice for those 2/3 of people that could benefit immediately, while also you know, not paying enough attention to some solutions that we can implement to improve access for that 1/3 that doesn't currently have technological access. And so I think there's some real opportunities to leverage implementation science in the policy research space to think about how our policies to expand telehealth and to support rural broadband access in particular being implemented. How are they being complied with or not? How are they being enforced so that we can make sure that we can actually leverage these policy and kind of more widespread interventions to equitably improve access to telehealth for folks who want it and could benefit from it.
Yeah, very astute. I like that. I also put a plug in cancer. Patients are often older, and that also there seems to be a perception that they also use technology to less a degree, but I think it's a bit more complex than that as well. So it's wonderful. Okay, I guess another question, see if we have any questions. I encourage people to type them in as we go. Think, I guess another question I might have for you are, both of you mentioned evaluation and thinking through kind of why you're doing it and how you're doing it. I guess I'm curious, telehealth again, trying to bring common bonds between the two kind of presentations. Like how do you recommend we think about measuring, evaluating quality of telehealth? Are we really aiming towards a goal of replacing a care visit, or is it supportive, or are we just not sure at this point how it works in care delivery in certain situations?
And so I think that's a very complicated answer, because I think there's multiple different elements to quality. So and I think we need to look at all of them. So that includes, the outright outcomes, like you highlighted in the prior question. The more robust use of telehealth is relatively new. We don't have a ton of long-term data in terms of, how telehealth being integrated into care and how that leads to long-term outcomes for patients in terms of both like healthcare utilization, but also just simple things in terms of, survival and ultimately satisfaction with care. So I do think there needs to be ongoing research just looking at those true standard quality metrics in terms of how care delivery strategies are affecting long-term outcomes. And I do think the more data that comes out about that will also support policy and also support confidence in clinicians using more of these types of services that are more patient-centered. Medicine tends to be one of the slowest things to adapt over time, and clinicians, particularly oncologists, want a lot of data before they do anything. And so the more data that we can show that patients have, either equitable or improved outcomes with different types of initiatives, I think the more support we're going to have to really have the policies needed to make this more accessible. And then at the same time, I think looking at the certain outcomes in terms of, patient satisfaction, quality of life, are we really moving the needle in terms of making care more patient-centered? And so are we making sure that we're not just making our assumptions that this is the best thing for somebody, but really looking at the patient and talking with them and seeing, does it work? Like, are we minimizing financial toxicity? Are we minimizing the burden on patients? Or are we really just changing the burden? And so instead, we were talking with enhanced telemedicine, are we doing a telehealth visit and then making the patient still have to drive 2 hours to go get their imaging study? Like, are we, so just, I think it's going to really take a combination of doing clinical research and combine it with implementation science and qualitative research methods to really look at this from a big picture perspective. And it's going to take us looking not only at the data that we've generated so far, but looking prospectively to kind of understanding the long-term implications of this.
Hey, Roxanne, there's 3 quickies in the Q&A box, and we're getting towards the end. Maybe you could just rattle those 3 off.
Sure, no problem. All right, these seem to be related to Dr. Bange's presentation. What type of injection drugs were administered at home by patients?
So we've been looking at particularly androgen deprivation therapy, so Lupron, Eligard, but we're also looking at denosumab as well, which is a subcutaneous injection that's used as a bone modifying agent for patients with either bone mets and breast cancer or castration, bone mets and castration resistant disease and prostate cancer.
And were drugs mailed to patients' home? And were there any problems? So
yeah, so the pharmacy and drug figuring out how to get the drugs approved and sent to the patients was something that definitely required a lot of time and effort. I think actually the bigger challenge was getting the drugs paid for, because usually we're administering them in clinic. So making sure that we get the prior authorizations done, that the drugs that we enact, that we have, the copay assistance programs enacted when they do have high copays, to make sure that we aren't adding on to financial toxicity to patients. That was actually the biggest burden to go over. once the drug is approved, if it's coming from our pharmacy, most specialty pharmacies already have programs in place to send medication, whether it was from our facility, our specialty pharmacy, or whether it was from CVS, they already had, infrastructure to do it. And so it was really actually the payment side that was more challenging and continues to be something that we're working on.
It's probably the last one here, Roxanne.
All right. So there's a question about the toxicities associated with bromizolab. And if they occur before 3 weeks, is there an option to kind of speed up the consult? Like, how flexible is the assessment schedule?
Yeah, so the protocol, the standard appointments are those 3-week and 6 weeks appointments. But obviously, what's beautiful about the enhanced telemedicine program is that we can be more nimble. And so let's say somebody calls in with a complaint and we want to do a telehealth assessment or have someone get a blood work done, we can actually enact those services in a way that's a lot more nimble than our standard approach. And what I have seen in my practice particularly is patients who live further away. So I'm based in New Jersey, and I have a lot of patients in Pennsylvania, even rural Pennsylvania, that's 3 hours away, and being able to, not have them have to drive all the way in to go see somebody in person, but be able to set up a video, have labs collected maybe the morning before, getting a blood pressure assessment. It really allows me to make a better decision and call in terms of, how are they doing? Do we need to escalate to bring them in, or are they doing fine at home and we can just give them some advice? And so that's a long-winded answer of saying yes, the ones I mentioned in the protocol are the standard ones, but we can be more nimble than that.
So with
Great.
that, we're at the top of the hour. I'd like to thank our speakers and our moderator for an excellent session. Again, this is recorded as well. Will be available in a few weeks. So I'd like to remind everyone of our next Cancer Moonshot Seminar, February 22nd, Advancing the Understanding and Treatment of Adult and Childhood Cancers with Cancer Biology. Speakers, Dr. Waller and Zimmerman. So thank you, everyone. Great session. Appreciate it.